Question 1. Compliance review shows that a radiation oncology department is exploring process optimization for patient treatment delivery. Which of the following approaches best aligns with the fundamental principles of radiation and regulatory expectations for patient care? Option A. Prioritizing the reduction of treatment session times by utilizing less precise beam shaping techniques, assuming that overall dose delivered remains within established prescription ranges. Option B. Implementing treatment delivery techniques that are validated through rigorous scientific study and demonstrate optimal dose conformity to the target volume, while minimizing dose to organs at risk, ensuring adherence to established radiobiological models. Option C. Relying on the experience of senior staff to guide treatment delivery modification, even if these modifications deviate from established protocols and lack a clear scientific rationale. Option D. Adopting new treatment delivery technologies based on preliminary marketing materials, without independent verification of their impact on dose distribution and biological effectiveness. The correct answer is B. Implementing treatment delivery techniques that are validated through rigorous scientific study and demonstrate optimal dose conformity to the target volume, while minimizing dose to organs at risk, ensuring adherence to established radiobiological models. Explanation. This scenario presents a professional challenge related to the fundamental principles of radiation, specifically concerning the application of radiation therapy. The challenge lies in ensuring that the chosen approach to treatment delivery aligns with established scientific understanding and regulatory requirements for patient safety and efficacy, while also considering the practicalities of process optimization. Careful judgment is required to balance these factors. The correct approach represents best professional practice because it prioritizes a thorough understanding of radiation physics and radiobiology to inform treatment planning and delivery. This aligns with the core principles of radiation oncology, which mandate that all treatment decisions be based on sound scientific evidence and aimed at maximizing therapeutic benefit while minimizing harm. Adherence to established protocols and guidelines, which are themselves derived from these fundamental principles, is a regulatory and ethical imperative. An incorrect approach that neglects the underlying physics of radiation interaction with tissue would be professionally unacceptable. This failure would represent a direct violation of the principle of providing evidence-based care and could lead to suboptimal treatment outcomes or increased toxicity. It also fails to meet the implicit regulatory expectation that practitioners possess and apply a deep understanding of the modalities they employ. Another incorrect approach that focuses solely on speed of delivery, without considering the biological impact of the radiation dose distribution, would be ethically and regulatorily flawed. This prioritizes efficiency over patient well-being, potentially compromising the precise targeting of the tumor and sparing of critical structures, which is a cornerstone of safe and effective radiation oncology. Such an approach could lead to underdosing the tumor or overdosing healthy tissues, both of which are unacceptable outcomes. A third incorrect approach that relies on anecdotal evidence or personal preference rather than established scientific principles and peer-reviewed data would also be professionally unacceptable. This deviates from the standard of care and introduces an unacceptable level of variability and potential for error, undermining patient trust and regulatory compliance. The professional reasoning process for similar situations should involve a systematic evaluation of the treatment plan against fundamental principles of radiation physics and radiobiology, current clinical guidelines, and institutional protocols. Professionals should critically assess how proposed optimizations impact dose distribution, biological effective dose, and the potential for normal tissue complications. Collaboration with medical physicists and other members of the radiation oncology team is crucial to ensure that any process optimization is scientifically sound, clinically appropriate, and compliant with all regulatory requirements. Question 2. Which approach would be most effective in evaluating the potential for radiation-induced damage in a patient with a complex tumor presentation, considering the underlying radiobiological mechanisms? Option A. Analyzing the patient's cellular DNA repair capacity and the potential role of reactive oxygen species in mediating radiation effects. Option B. Focusing exclusively on the accuracy of the external beam delivery parameters and isodose lines. Option C. Relying solely on established dose-volume histograms and historical outcomes for similar tumor sites. Option D. Prioritizing the speed of treatment delivery to minimize patient inconvenience. The correct answer is A. Analyzing the patient's cellular DNA repair capacity and the potential role of reactive oxygen species in mediating radiation effects. Explanation. This scenario presents a professional challenge in accurately assessing and managing the potential for radiation-induced damage in a patient undergoing a complex radiation oncology treatment. The challenge lies in integrating knowledge of radiobiology, treatment planning, and patient-specific factors to predict and mitigate adverse effects, ensuring adherence to established safety standards and best practices. Careful judgment is required to balance treatment efficacy with patient safety, necessitating a thorough understanding of the underlying mechanisms of radiation damage. The correct approach represents best professional practice because it directly addresses the core mechanisms of radiation-induced damage by focusing on cellular and molecular responses. This aligns with the fundamental principles of radiation oncology, which aim to deliver a therapeutic dose while minimizing collateral damage to healthy tissues. By considering factors such as DNA repair capacity, cell cycle progression, and the role of reactive oxygen species, clinicians can make more informed decisions regarding treatment fractionation, dose escalation, and the use of radioprotective or radiosensitizing agents. This proactive and mechanism-based evaluation is crucial for optimizing patient outcomes and adhering to the ethical imperative of do no harm. Regulatory frameworks in radiation oncology emphasize evidence-based practice and the continuous pursuit of improved patient safety, which are best served by a deep understanding of radiation biology. An incorrect approach that relies solely on historical dose-response data without considering the specific biological context fails to account for individual patient variability and the complex interplay of factors influencing radiation sensitivity. This can lead to suboptimal treatment planning and an increased risk of both undertreatment and overtreatment, potentially resulting in treatment failure or unacceptable toxicity. Ethically, this approach falls short of the standard of care by not fully utilizing available scientific knowledge to personalize treatment and protect the patient. Another incorrect approach that prioritizes treatment speed over a comprehensive biological assessment overlooks the critical importance of understanding the mechanisms of damage. While efficiency is a consideration, it should not come at the expense of thoroughness in evaluating potential harm. This can lead to overlooking subtle but significant biological factors that could influence treatment outcomes or increase the risk of long-term side effects. Regulatory guidelines mandate a comprehensive evaluation of treatment plans, which includes understanding the biological rationale behind dose and fractionation decisions. A third incorrect approach that focuses exclusively on external beam parameters without delving into the cellular and molecular consequences of radiation exposure is also professionally deficient. While accurate dose delivery is paramount, it is the biological impact of that dose that ultimately determines the therapeutic effect and potential for damage. Ignoring the mechanisms of radiation-induced damage means missing opportunities to predict, prevent, or manage adverse events at a fundamental level. This is contrary to the principles of radiation biology and the regulatory emphasis on understanding the full spectrum of radiation effects. The professional decision-making process for similar situations should involve a systematic evaluation that begins with a thorough understanding of the patient's diagnosis and overall health status. This should be followed by a detailed review of the proposed treatment plan, considering not only the physical dose distribution, but also the radiobiological implications. Clinicians should actively consider factors that influence cellular radiosensitivity, such as tumor type, genetic mutations, and the patient's individual biological response. This mechanistic understanding should then inform decisions regarding treatment fractionation, dose adjustments, and the potential use of adjunct therapies. Continuous learning and staying abreast of advancements in radiobiology are essential for maintaining best practice and ensuring patient safety within the regulatory framework. Question 3. The review process indicates a patient with locally advanced non-small cell lung cancer is being considered for concurrent chemoradiation. The proposed systemic therapy involves a novel targeted agent with limited published data on its interaction with radiation. Which of the following represents the most appropriate next step in the decision-making framework? Option A. Convene a multidisciplinary tumor board meeting including radiation oncology, medical oncology, and relevant subspecialists to discuss the patient's case, review available literature on the targeted agent's radiosensitizing or radioprotective properties, and formulate a consensus treatment plan. Option B. Administer the targeted agent at a reduced dose and delay the start of radiation therapy until the patient's tolerance to the systemic agent is fully assessed. Option C. Focus solely on optimizing the radiation therapy dose and fractionation, deferring any detailed discussion of systemic therapy interactions until after radiation completion. Option D. Proceed with the planned radiation therapy while initiating the targeted agent as per the medical oncologist's standard protocol, assuming no significant interactions based on general principles of systemic therapy. The correct answer is A. Convene a multidisciplinary tumor board meeting including radiation oncology, medical oncology, and relevant subspecialists to discuss the patient's case, review available literature on the targeted agent's radiosensitizing or radioprotective properties, and formulate a consensus treatment plan. Explanation. This scenario presents a professional challenge due to the inherent complexity of integrating systemic therapies with radiation oncology, requiring a nuanced understanding of potential toxicities, synergistic effects, and patient-specific factors. The decision-making process must be grounded in evidence-based guidelines and a thorough assessment of individual patient risk and benefit. The correct approach represents best professional practice by prioritizing a multidisciplinary discussion and a comprehensive review of the patient's overall health status and treatment goals. This aligns with the ethical imperative to provide patient-centered care and adhere to established clinical practice guidelines, which often mandate such collaborative decision-making for complex treatment regimens. Regulatory frameworks emphasize the importance of evidence-based medicine and the physician's responsibility to ensure patient safety and optimal outcomes. An incorrect approach that proceeds with systemic therapy without a thorough discussion of potential interactions and side effects with the radiation oncology team fails to uphold the standard of care. This could lead to unforeseen toxicities, compromised treatment efficacy, and potential harm to the patient, violating principles of beneficence and non-maleficence. It also represents a failure to adhere to regulatory expectations for coordinated patient care and risk management. Another incorrect approach, focusing solely on the radiation oncology plan without adequately considering the systemic agent's impact on radiation sensitivity or toxicity, overlooks critical aspects of integrated care. This can result in suboptimal treatment planning and increased risk of radiation-induced side effects, contravening the principle of providing the most effective and least harmful treatment. A further incorrect approach, prioritizing patient preference for a specific systemic agent without a robust discussion of its integration with radiation and potential consequences, neglects the physician's responsibility to guide treatment based on medical evidence and safety. While patient autonomy is crucial, it must be exercised within the bounds of medically sound recommendations. The professional reasoning framework for such situations involves 1. Thoroughly reviewing the patient's medical history, comorbidities, and performance status. 2. Consulting relevant evidence-based guidelines for the specific cancer type and stage, including recommendations for combined modality treatment. 3. Engaging in a multidisciplinary team discussion involving radiation oncology, medical oncology, and potentially other specialists to assess potential drug-radiation interactions, synergistic effects, and additive toxicities. 4. Conducting a comprehensive risk-benefit analysis for the proposed integrated treatment plan. 5. Clearly communicating the rationale, potential benefits, risks, and alternatives to the patient, ensuring informed consent. Question 4. The analysis reveals that a novel therapeutic strategy aims to enhance radiation sensitivity by targeting specific immunosuppressive cells within the tumor microenvironment. Considering the regulatory framework for radiation oncology certification, which of the following represents the most appropriate approach for a radiation oncologist to consider when evaluating the integration of such a strategy into patient care? Option A. Immediately incorporate the TME modulating agent into standard treatment regimens for eligible patients, assuming that novel research inherently translates to improved clinical outcomes. Option B. Prioritize the evaluation of robust preclinical data and early-phase clinical trial results demonstrating the efficacy and safety of the TME modulating agent in conjunction with radiation, and consider its adoption within approved clinical trials or institutional protocols. Option C. Reject the strategy outright due to its absence in current, widely published standard of care treatment guidelines. Option D. Implement the TME modulating agent based on anecdotal reports from colleagues and promotional materials from the drug manufacturer, without further independent scientific validation. The correct answer is B. Prioritize the evaluation of robust preclinical data and early-phase clinical trial results demonstrating the efficacy and safety of the TME modulating agent in conjunction with radiation, and consider its adoption within approved clinical trials or institutional protocols. Explanation. Scenario analysis. This scenario presents a professional challenge in integrating emerging research on the tumor microenvironment, TME, into established radiation oncology treatment paradigms. The difficulty lies in translating complex biological insights into actionable clinical decisions that demonstrably improve patient outcomes while adhering to current evidence-based standards and regulatory guidelines. Clinicians must balance the potential benefits of novel approaches with the need for robust validation and the inherent risks associated with deviating from established protocols. This requires a deep understanding of both the scientific underpinnings of TME modulation and the practical implications for treatment planning and delivery. Correct approach analysis. The correct approach involves a systematic and evidence-based integration of TME modulating strategies. This means carefully evaluating preclinical and early-phase clinical data demonstrating the efficacy and safety of specific interventions in conjunction with radiation therapy. It necessitates a thorough understanding of the biological rationale for targeting particular TME components, e.g., immune cells, stromal components, hypoxia, in relation to radiation sensitivity. Best professional practice dictates that such integration should occur within the framework of well-designed clinical trials, or through adherence to institutional review board-approved protocols. This ensures that patient care is guided by rigorous scientific inquiry, ethical considerations, and regulatory oversight, ultimately aiming to improve therapeutic ratios and patient outcomes. The focus remains on evidence generation and responsible adoption of novel therapies. Incorrect approaches analysis. One incorrect approach would be to unilaterally implement TME modulating agents without sufficient preclinical or clinical validation, or without appropriate ethical and regulatory approval. This represents a failure to adhere to the principles of evidence-based medicine and may expose patients to unknown risks or ineffective treatments, violating the ethical obligation to provide safe and effective care. Such an approach bypasses the necessary scientific scrutiny and regulatory oversight designed to protect patient welfare. Another incorrect approach would be to dismiss the potential of TME modulation entirely due to a lack of widespread adoption in current standard of care guidelines. While adherence to established protocols is crucial, a complete disregard for promising research can hinder progress and deny patients access to potentially superior treatments. This reflects a lack of engagement with evolving scientific knowledge and a failure to critically assess new evidence, potentially leading to suboptimal patient care. A third incorrect approach would be to adopt TME modulating strategies based solely on anecdotal evidence or marketing claims without rigorous scientific validation. This approach prioritizes unsubstantiated claims over established scientific principles and regulatory requirements, posing significant risks to patient safety and treatment efficacy. It demonstrates a failure to critically evaluate information and a disregard for the ethical imperative to base clinical decisions on robust evidence. Professional reasoning. Professionals should approach the integration of TME modulating strategies by first conducting a comprehensive literature review of preclinical and clinical data. This should be followed by a critical assessment of the biological plausibility and potential clinical benefit. Decisions regarding implementation should be made in consultation with multidisciplinary teams, including radiation oncologists, medical oncologists, medical physicists, and research scientists. Any novel approach should ideally be pursued within the context of a clinical trial or a carefully designed institutional protocol, subject to Institutional Review Board (IRB) approval. This ensures that patient care is both innovative and ethically sound, adhering to all applicable regulatory frameworks and professional standards. The decision-making process must prioritize patient safety, evidence-based practice, and continuous learning. Question 5. Benchmark analysis indicates that when planning photon beam radiation therapy, the conversion of imaging data into electron density for dose calculation is a critical step. Considering the physical principles of different imaging modalities commonly used in radiation oncology, which of the following approaches most accurately reflects the established methodology for ensuring accurate dose deposition calculations? Option A. Employing MRI signal intensities as a direct substitute for electron density in photon beam dose calculations. Option B. Directly using Hounsfield units from CT scans without further conversion, assuming they directly correlate with electron density. Option C. Utilizing CT-derived electron density values, calibrated against known phantoms, as the basis for dose calculation algorithms. Option D. Incorporating PET scan tracer uptake values to represent tissue density for dose calculation purposes. The correct answer is C. Utilizing CT-derived electron density values, calibrated against known phantoms, as the basis for dose calculation algorithms. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology where different imaging modalities are used for treatment planning. The professional challenge lies in understanding the fundamental physical differences between these modalities and how they impact dose calculation and the resulting radiation distribution. Misinterpreting these differences can lead to inaccurate dose delivery, potentially compromising treatment efficacy or increasing toxicity. Careful judgment is required to select the most appropriate imaging technique for the specific clinical scenario, and to ensure the physics of dose calculation is correctly applied. Correct approach analysis. The correct approach recognizes that CT imaging, while providing excellent anatomical detail, relies on the attenuation of X-rays, which is directly related to the electron density of the material. This electron density is then used to derive the mass density, and ultimately the electron density relative to water, which is crucial for accurate photon beam dose calculations. This method is the established standard in radiation oncology physics for converting CT numbers into tissue-equivalent densities for dose calculation algorithms, ensuring that the physics principles underpinning dose deposition are correctly applied within the regulatory framework governing radiation oncology practice. Incorrect approaches analysis. One incorrect approach might assume that the Hounsfield units, who directly represent electron density, without considering the underlying physics of X-ray attenuation and the calibration of the CT scanner. This oversight fails to account for the fact that HU values are relative and require conversion to electron density for accurate dose calculation, a fundamental principle in radiation physics. Another incorrect approach could be to prioritize the visual anatomical detail of MRI over its quantitative density information for dose calculation. While MRI provides superior soft tissue contrast, its signal intensity is not directly proportional to electron density in a way that can be readily used by standard photon dose calculation algorithms. Attempting to directly use MRI signal intensities for dose calculation without proper conversion or specialized algorithms would violate the established physics principles and regulatory requirements for accurate dose planning. A further incorrect approach might involve using PET imaging data directly for dose calculation without understanding that PET measures metabolic activity, not tissue density. While PET can be valuable for defining tumor extent and biological targets, its data is not directly applicable to the physical calculation of radiation dose deposition, which is based on attenuation properties. Professional reasoning. Professionals should approach such scenarios by first identifying the primary purpose of the imaging modality in the context of radiation therapy planning. For dose calculation, the ability to accurately represent tissue electron density is paramount. This requires understanding the physical principles behind each imaging technique and how its data is processed for dose planning. Professionals should consult established physics literature, institutional protocols, and regulatory guidelines to ensure their chosen methods align with best practices and ensure patient safety and treatment efficacy. When in doubt, collaboration with qualified medical physicists is essential. Question 6. System analysis indicates a patient presence with a newly diagnosed glioblastoma multiforme, exhibiting a high proliferation index and specific genetic mutations associated with impaired DNA repair mechanisms. The multidisciplinary tumor board is considering treatment options. Which of the following approaches best integrates the understanding of this tumor's biology into the radiation oncology treatment plan? Option A. Recommending a prolonged period of observation and further extensive molecular subtyping before initiating any radiation therapy. Option B. Focusing solely on palliative radiation to manage symptoms, given the aggressive biological markers, without attempting curative intent. Option C. Designing a radiation therapy plan that incorporates a higher dose per fraction or altered fractionation schedule, potentially combined with targeted agents that exploit the identified DNA repair deficiencies to enhance tumor cell kill. Option D. Administering a standard dose and fractionation regimen for glioblastoma, as per established protocols, without further modification. Correct answer is D. Administering a standard dose and fractionation regimen for glioblastoma as per established protocols without further modification. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology where a patient's tumor exhibits aggressive biological characteristics, necessitating a tailored treatment approach. The challenge lies in integrating complex molecular and cellular information into a practical and effective radiation treatment plan, while adhering to established clinical guidelines and ensuring patient safety. The physician must balance the urgency dictated by tumor biology with the need for a well-defined and evidence-based strategy. Correct approach analysis. The correct approach involves a comprehensive review of the tumor's molecular profile, including genetic mutations and protein expression, to understand its intrinsic radioresistance or radiosensitivity. This information is then used to inform the selection of appropriate radiation dose fractionation, potentially incorporating novel radiobiological concepts or advanced treatment techniques that can overcome specific resistance mechanisms. This aligns with the principles of precision medicine and evidence-based practice, aiming to optimize therapeutic outcomes while minimizing toxicity. The regulatory framework for radiation oncology certification emphasizes the importance of understanding tumor biology to guide treatment decisions, ensuring that care is personalized and effective. Incorrect approaches analysis. One incorrect approach would be to proceed with a standard, non-tailored radiation protocol without considering the specific biological features of the tumor. This fails to leverage critical information that could significantly impact treatment efficacy and patient outcomes, potentially leading to suboptimal control of a biologically aggressive cancer. This approach disregards the advancements in understanding cancer biology and its implications for radiation response, which is a core competency expected of certified professionals. Another incorrect approach would be to solely rely on anecdotal evidence or unproven experimental therapies without a strong biological rationale or robust clinical data. This poses a significant risk to the patient, potentially exposing them to ineffective or harmful treatments. It violates ethical principles of beneficence and non-maleficence, and may contraindicate established regulatory guidelines that mandate evidence-based practice. A third incorrect approach would be to delay treatment significantly while awaiting further, potentially unnecessary, extensive biological investigations that do not directly inform the immediate treatment strategy. While thoroughness is important, an undue delay in treating an aggressive tumor can allow for progression, diminishing the chances of successful treatment. This demonstrates a failure in clinical judgment and timely decision-making, which is a critical aspect of patient care and professional responsibility. Professional reasoning. Professionals should adopt a systematic approach that begins with a thorough understanding of the patient's clinical presentation and diagnostic findings. This includes integrating all available biological data, such as molecular profiling, into the decision-making process. The next step is to consult relevant clinical guidelines and evidence-based literature to identify treatment options that are supported by data and appropriate for the specific tumor biology. If the tumor exhibits unique or aggressive characteristics, a multidisciplinary tumor board discussion is often beneficial to gain diverse perspectives and refine the treatment strategy. Finally, the chosen treatment plan must be clearly communicated to the patient, with a thorough discussion of potential benefits, risks, and alternatives, ensuring informed consent. Question 7. During the evaluation of a recently calibrated ion chamber used for routine patient dosimetry, the quality assurance physicist notes a drift of 1.5% from its previous calibration value. according to the facility's established quality assurance program, which is compliant with all relevant U.S. regulatory frameworks for radiation oncology. What is the most appropriate immediate next step? Option A. Immediately remove the ion chamber from clinical service and send it for recalibration. Option B. Perform an immediate recalibration of the ion chamber without further documentation or comparison to tolerance limits. Option C. Continue using the ion chamber for patient treatments, assuming the drift is within acceptable clinical margins. Option D. Document the observed drift and compare it against the established tolerance limits for acceptable performance as defined by regulatory guidelines and manufacturer specifications. The correct answer is A. Immediately remove the ion chamber from clinical service and send it for recalibration. Explanation: scenario analysis. This scenario presents a professional challenge in ensuring the accuracy and reliability of radiation measurement tools, which directly impacts patient safety and treatment efficacy. The challenge lies in interpreting the implications of a specific calibration drift on clinical practice and regulatory compliance, without resorting to immediate, potentially unnecessary, corrective actions. It requires a nuanced understanding of acceptable tolerances and the potential consequences of both overcorrection and undercorrection. Correct approach analysis. The correct approach involves a thorough review of the observed calibration drift against established regulatory limits and manufacturer specifications. This aligns with best professional practice by prioritizing evidence-based decision-making. Specifically, it adheres to the principles of quality assurance and patient safety mandated by regulatory bodies, which require that all radiation-producing equipment and measurement devices are maintained within acceptable performance parameters. This approach ensures that any action taken is justified, proportionate, and minimizes unnecessary disruption to patient care while upholding safety standards. Incorrect approaches analysis. One incorrect approach involves immediately removing the ion chamber from clinical use solely based on the observed drift, without first comparing it to established tolerance limits. This fails to acknowledge that minor drifts within acceptable ranges are often permissible and do not necessarily compromise dosimetry accuracy to a clinically significant degree. This action could lead to unnecessary downtime, increased costs, and potential delays in patient treatment, violating principles of efficient resource management and patient-centered care. It also bypasses the established quality assurance protocols that define acceptable drift parameters. Another incorrect approach is to continue using the ion chamber without any further investigation, assuming the drift is insignificant. This is a critical regulatory and ethical failure. It directly contravenes the requirement for regular calibration and performance checks of dosimetry equipment. Ignoring a drift, even if seemingly minor, could lead to cumulative inaccuracies in delivered dose, potentially resulting in undertreatment or overtreatment of patients, which is a direct threat to patient safety and a violation of professional responsibility and regulatory mandates for accurate dosimetry. A third incorrect approach is to recalibrate the ion chamber immediately without documenting the observed drift and comparing it to the established tolerance. While recalibration might eventually be necessary, skipping the documentation and comparison step means losing valuable data about the instrument's performance history. This hinders effective quality assurance trending and makes it difficult to identify patterns of potential equipment malfunction or to justify the recalibration to regulatory bodies or for internal audits. It represents a failure in systematic record-keeping and adherence to quality management system requirements. Professional reasoning. Professionals should approach such situations by first consulting the relevant regulatory guidelines and manufacturer specifications for acceptable calibration tolerances. This forms the basis for evaluating the significance of any observed drift. The next step is to meticulously document the findings and compare them against these established limits. If the drift is within tolerance, continued monitoring and documentation are appropriate. If the drift exceeds tolerance, then a corrective action, such as recalibration or replacement, is warranted, following established protocols. This systematic, data-driven approach ensures that decisions are defensible, compliant, and prioritize patient safety and treatment accuracy. Question 8. Market research demonstrates that while advanced treatment planning techniques can achieve highly conformal dose distributions, there is variability in how oncologists interpret and apply dose constraints for organs at risk when planning radiation therapy for prostate cancer. A patient presents with localized prostate cancer requiring definitive external beam radiation therapy. The treatment planning system allows for precise dose sculpting, considering the goal of maximizing tumor control while minimizing rectal and bladder toxicity. Which of the following approaches to dose distribution best reflects current best practices and regulatory expectations for this scenario? Option A. Rely on the default dose distribution parameters generated by the treatment planning system without further optimization, assuming these are preset to meet all clinical and regulatory requirements. Option B. Prioritize achieving the prescribed dose to the planning target volume, PTV, with minimal deviation, ensuring that the dose to the rectum and bladder are within generally accepted tolerance limits as defined by established clinical protocols and professional society guidelines. Option C. Adjust the dose distribution based on the physician's personal experience with similar cases, prioritizing a specific dose gradient around the PTV that has yielded favorable outcomes in their past practice, irrespective of established dosimetric constraints for OARs. Option D. Focus on achieving the absolute lowest possible dose to the rectum and bladder, even if it means slightly compromising the uniformity of dose delivery within the PTV, to proactively prevent any potential long-term toxicity. The correct answer is B. Prioritize achieving the prescribed dose to the planning target volume, PTV, with minimal deviation, ensuring that the dose to the rectum and bladder are within generally accepted tolerance limits as defined by established clinical protocols and professional society guidelines. Explanation. This scenario presents a professional challenge due to the inherent complexity of radiation oncology treatment planning, specifically concerning dose distribution, and its impact on both tumor control and normal tissue toxicity. The physician must balance achieving adequate tumoricidal doses with minimizing radiation exposure to critical organs at risk, or a core tenet of radiation oncology practice. This requires a deep understanding of radiobiology, treatment planning system capabilities, and adherence to established clinical guidelines and regulatory standards. The challenge is amplified by the need to interpret and apply these principles in a real-world patient context, where individual anatomical variations and treatment goals necessitate tailored approaches. The correct approach represents best professional practice because it prioritizes patient safety and efficacy by adhering to established dosimetric constraints and clinical guidelines. This aligns with regulatory frameworks that mandate the use of evidence-based practices and the optimization of treatment plans to achieve desired clinical outcomes while respecting OAR tolerance limits. Specifically, it reflects the professional obligation to ensure that the prescribed dose is delivered to the target volume with acceptable uniformity, and that doses to OARs remain within acceptable limits to prevent or minimize treatment-related morbidity. This approach is grounded in the principles of ALARA, as low as reasonably achievable, for normal tissues and maximizing tumor control probability, as guided by professional societies and regulatory bodies. An incorrect approach that focuses solely on achieving the prescribed dose to the planning target volume, PTV, without adequate consideration for dose distribution within the PTV or to OARs would be professionally unacceptable. This failure would represent a violation of the principle of minimizing harm, as it could lead to increased toxicity and potentially compromise the patient's quality of life. Regulatory failure would stem from not meeting standards for dose conformity and OAR sparing, which are often explicitly or implicitly addressed in accreditation and quality assurance guidelines. Another incorrect approach that prioritizes OAR sparing to an extent that compromises adequate tumor coverage would also be professionally unacceptable. This would fail to meet the primary objective of radiation oncology, to effectively treat the malignancy. Ethically, this would represent a failure to provide the most effective treatment available, potentially leading to treatment failure and adverse patient outcomes. Regulatory failure would occur if the treatment plan deviates from established protocols for target volume coverage, thereby failing to meet the standard of care. A third incorrect approach that relies on anecdotal evidence or personal preference, without referencing established dosimetric parameters or clinical guidelines, would be professionally unsound. This approach lacks the rigor and objectivity required for safe and effective radiation therapy. It would be a significant regulatory and ethical failure, as it bypasses the established scientific and clinical evidence base that underpins radiation oncology practice and regulatory oversight. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's diagnosis, stage, and treatment goals. This should be followed by a thorough review of relevant clinical guidelines and dosimetric constraints for the specific disease site and treatment modality. The treatment planning system should be utilized to generate a plan that optimizes target coverage while respecting OAR tolerance limits. Peer review and consultation with colleagues, particularly in complex cases, are essential components of this process to ensure a robust and evidence-based treatment plan. Continuous professional development and staying abreast of evolving research and guidelines are also critical. Question 9. Benchmark analysis indicates that treatment planning in radiation oncology requires a careful balance between tumor coverage and organ at risk or sparing. When reviewing a dose volume histogram, DVH, for a complex treatment plan, which of the following represents the most critical consideration for ensuring both efficacy and patient safety? Option A. Ensuring that the dose delivered to the planning target volume, PTV, meets or exceeds the prescribed dose, while simultaneously verifying that the dose to critical OARs remains within established tolerance limits, as defined by clinical protocols and radiobiological principles. Option B. Relying solely on the automated optimization algorithm of the treatment planning system to generate a plan that meets all objectives without requiring extensive manual review of the DVH data. Option C. Focusing exclusively on achieving the prescribed dose to the PTV, with minimal regard for the dose received by OARs, to maximize the probability of tumor eradication. Option D. Prioritizing the absolute lowest possible dose to all OARs, even if it means a slight reduction in dose to the PTV, to minimize any potential for treatment-related side effects. The correct answer is A. Ensuring that the dose delivered to the planning target volume, PTV, meets or exceeds the prescribed dose, while simultaneously verifying that the dose to critical OARs remains within established tolerance limits, as defined by clinical protocols and radiobiological principles. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology treatment planning, balancing the need for effective tumor control with the imperative to minimize dose to critical organs at risk or. The professional challenge lies in interpreting complex dose volume histogram, DVH, data and understanding its implications for potential toxicity, while also adhering to established clinical protocols and institutional guidelines. The physician must make a judgment call based on the available data and their understanding of radiobiology and clinical outcomes, recognizing that deviations from standard practice require robust justification. Correct approach analysis. The correct approach involves a thorough review of the DVH data in conjunction with the patient's specific clinical presentation and the established treatment planning objectives. This includes evaluating whether the OAR constraints are being met within acceptable limits, considering the potential for dose escalation to the tumor if OAR sparing is compromised, and assessing the overall risk-benefit profile. This approach aligns with the principles of ALARA, as low as reasonably achievable for OARs, while ensuring adequate coverage for tumor control, as mandated by ethical practice and regulatory expectations for patient safety and quality of care. It requires a nuanced understanding of dose-volume relationships and their correlation with clinical outcomes, reflecting a commitment to evidence-based medicine and patient-centered care. Incorrect approach is analysis. One incorrect approach would be to solely focus on achieving the absolute lowest possible dose to all OARs, even if it compromises tumor coverage or necessitates a less optimal beam arrangement. This could lead to undertreatment of the tumor, reducing the chances of local control and potentially impacting survival. This fails to meet the primary objective of cancer treatment and could be considered a deviation from best practice, potentially violating principles of providing effective care. Another incorrect approach would be to disregard the OAR constraints entirely and prioritize tumor coverage above all else, leading to excessive dose to critical structures. This significantly increases the risk of acute and late toxicities, which can severely impact the patient's quality of life and potentially lead to treatment discontinuation or severe morbidity. This approach would likely violate regulatory guidelines emphasizing patient safety and the minimization of harm. A third incorrect approach would be to rely solely on automated planning systems without critical physician oversight and review of the DVH data. While these systems can be valuable tools, They may not always account for subtle clinical nuances or the specific radiobiological characteristics of the tumor and surrounding tissues. Over-reliance on automation without expert validation can lead to suboptimal plans that do not adequately address the individual patient's needs or adhere to established safety standards. Professional reasoning. Professionals should approach treatment planning by first understanding the specific clinical scenario and the treatment goals. This involves a comprehensive review of imaging, pathology, and patient factors. Next, they should consult relevant clinical guidelines and institutional protocols for target volume delineation and OAR constraints. The treatment plan should then be generated, followed by a meticulous review of the DVH data, comparing it against the established constraints and objectives. This review should critically assess the trade-offs between tumor coverage and OAR sparing. If the plan deviates significantly from expectations or presents a high risk of toxicity, further optimization or replanning should be considered. The final decision should be based on a reasoned assessment of the risk-benefit ratio for the individual patient, ensuring that the plan is both effective and safe and documented appropriately. Question 10. Regulatory review indicates a need to refine protocols for managing potential long-term sequelae of radiation therapy. Considering the biological effects of radiation, which approach best aligns with current regulatory expectations for minimizing deterministic and stochastic risks in patients undergoing curative intent radiation oncology treatment? Option A. Relying on post-treatment follow-up alone to identify and manage any late radiation effects that may arise, without proactive risk stratification. Option B. Conducting a thorough pre-treatment assessment of individual patient factors that may influence radiation sensitivity and incorporating these into a personalized treatment plan with optimized dose constraints for organs at risk. Option C. Prioritizing dose escalation to the gross tumor volume without specific consideration for dose constraints to adjacent organs at risk, focusing solely on maximizing local control. Option D. Implementing a standardized dose and fractionation schedule for all patients within a specific tumor site, assuming average radiobiological response. The correct answer is D. Implementing a standardized dose and fractionation schedule for all patients within a specific tumor site, assuming average radiobiological response. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent variability in individual patient responses to radiation therapy, particularly concerning the late biological effects. Accurately predicting and managing these effects requires a deep understanding of radiobiology, patient-specific factors, and adherence to established clinical guidelines and regulatory frameworks. The challenge lies in balancing the therapeutic benefit of radiation with the potential for long-term harm, necessitating careful consideration of dose, fractionation, and treatment planning to minimize stochastic and deterministic effects. Correct approach analysis. The correct approach involves a comprehensive assessment of the patient's individual risk factors for developing late radiation effects, such as pre-existing comorbidities, genetic predispositions, and concurrent treatments. This assessment informs a personalized treatment plan that prioritizes dose optimization to the target volume, while minimizing dose to organs at risk, thereby reducing the likelihood and severity of late toxicities. This aligns with the regulatory framework's emphasis on patient safety and the ALARA, as low as reasonably achievable, principle, ensuring that radiation exposure is justified and minimized. Best professional practice dictates a proactive approach to risk stratification and mitigation, supported by evidence-based guidelines for radiation oncology. Incorrect approaches analysis. One incorrect approach would be to solely rely on standard dose and fractionation schedules without considering individual patient factors. This fails to acknowledge the biological variability in radiation response and can lead to an increased risk of late effects in susceptible individuals, violating the principle of individualized care and potentially contravening regulatory requirements for patient-specific treatment planning. Another incorrect approach would be to prioritize aggressive dose escalation for tumor control without adequately assessing or managing the associated risks of late toxicity to critical structures. This overlooks the deterministic effects of radiation, which are dose-dependent and can lead to significant morbidity. Regulatory frameworks mandate a careful balance between efficacy and toxicity, requiring a thorough risk-benefit analysis. A third incorrect approach would be to dismiss patient-reported symptoms of potential late effects as unrelated to radiation without further investigation. This neglects the importance of ongoing patient monitoring and symptom management, which is crucial for detecting and addressing radiation-induced toxicities early. Regulatory oversight often includes requirements for follow-up care and adverse event reporting. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough understanding of the patient's medical history, including any factors that might influence radiation sensitivity. This is followed by a detailed review of the treatment plan, focusing on dose distributions to critical organs at risk and considering the potential for both early and late biological effects. Consultation with multidisciplinary teams, including radiation oncologists, medical physicists, and dosimetrists, is essential for optimizing treatment strategies. Furthermore, staying abreast of the latest research and clinical guidelines regarding radiation biology and toxicity management is paramount. Adherence to regulatory standards and ethical principles, such as beneficence and non-maleficence, guides the entire process, ensuring that patient safety and well-being are prioritized throughout the course of treatment and follow-up. Question 11. The evaluation methodology shows a radiation oncologist reviewing the initial contouring of a patient's prostate and seminal vesicles for a definitive radiotherapy plan. The oncologist notes that the seminal vesicle contours appear to be significantly smaller than typically seen in institutional protocols for this stage of disease, potentially excluding a portion of the seminal vesicle that is considered at risk for microscopic spread. The oncologist is also presented with the dose constraints for the rectum and bladder, which are already closed to their upper limits based on the initial target volume. Which of the following actions best represents the appropriate professional and regulatory approach in this scenario? Option A. Adjust the seminal vesicle contours to encompass the entire seminal vesicle structure, as per standard anatomical definitions and institutional guidelines, while re-evaluating the treatment plan to ensure OAR dose constraints are met, potentially through advanced planning techniques or dose escalation strategies if clinically indicated and feasible. Option B. Immediately expand the seminal vesicle contours to include a larger margin around the entire prostate, regardless of anatomical boundaries or specific risk assessment, to ensure no potential disease is missed, even if it significantly increases the dose to the rectum and bladder. Option C. Accept the initial seminal vesicle contours as provided, prioritizing the avoidance of exceeding OAR dose constraints, and proceed with treatment planning without further investigation into the potentially inadequate target coverage. Option D. Proceed with the initial contours without modification, assuming the referring physician has made appropriate clinical judgments, and focus solely on optimizing the dose distribution within the existing volumes. Correct answer is A. Adjust the seminal vesicle contours to encompass the entire seminal vesicle structure as per standard anatomical definitions and institutional guidelines, while re-evaluating the treatment plan to ensure OAR dose constraints are met, potentially through advanced planning techniques or dose escalation strategies if clinically indicated and feasible. Explanation. The evaluation methodology shows a scenario where a radiation oncologist is reviewing contouring data for a patient undergoing radiotherapy for a head and neck malignancy. The challenge lies in balancing the need for precise target volume delineation to maximize tumor control with the imperative to minimize radiation dose to critical organs at risk or to prevent treatment-related toxicity. This requires a deep understanding of relevant anatomy, tumor biology, treatment planning principles, and adherence to established guidelines. The professional challenge is amplified by potential inter-observer variability in contouring, the complexity of the specific tumor site, and the need to justify contouring decisions based on evidence and regulatory requirements. The correct approach represents best professional practice because it prioritizes patient safety and adherence to established standards of care, which are foundational to regulatory compliance and ethical practice in radiation oncology. Specifically, it involves a systematic review of the provided contours against established institutional protocols and national guidelines, e.g., OPM-TG reports, ESTRO recommendations, or equivalent U.S.-based guidelines if U.S. jurisdiction is implied for the exam. This ensures that the target volumes are adequately encompassing the known extent of disease while respecting the dose constraints for OARs, thereby optimizing the therapeutic ratio. This approach is ethically sound as it upholds the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Regulatory frameworks mandate accurate and consistent contouring for effective and safe treatment delivery. An incorrect approach that relies solely on the initial physician's contouring without independent verification or consideration of updated imaging or guidelines represents a failure to uphold the standard of care. This could lead to underdosing of the target volume, potentially compromising tumor control, or overdosing of OARs, increasing the risk of acute and late toxicities. Ethically, this demonstrates a lack of due diligence and a potential violation of the physician's responsibility to provide competent care. Regulatory failure would stem from not adhering to established quality assurance processes for treatment planning, which are critical for patient safety and consistent outcomes. Another incorrect approach that prioritizes speed over accuracy, perhaps by accepting contours without critical evaluation or by making arbitrary adjustments, is professionally unacceptable. This approach disregards the meticulous nature of radiation oncology treatment planning and can lead to significant clinical errors. It violates the ethical principle of competence and the regulatory requirement for a robust quality assurance program. A third incorrect approach that ignores established dose constraints for OARs in favor of aggressive target coverage, without clear clinical justification or a well-documented rationale, is also a significant professional and regulatory failure. While maximizing target coverage is important, it must be balanced against the potential for severe toxicity. This approach demonstrates a disregard for patient well-being and a failure to adhere to established safety protocols, which are often codified in regulatory requirements. The professional decision-making process for similar situations should involve a structured review of all available data, including imaging, pathology reports, and patient history. This should be followed by a critical evaluation of the contoured volumes against established protocols, guidelines, and dose constraints. Any discrepancies or uncertainties should be addressed through consultation with colleagues, further imaging, or adjustments to the contouring. The rationale for all decisions must be clearly documented in the patient's record, ensuring transparency and accountability. This systematic approach ensures that treatment plans are safe, effective, and compliant with all relevant regulatory and ethical standards. Question 12. The performance metrics show a high rate of successful treatment for locally advanced non-small cell lung cancer, NSCLC, in patients without significant comorbidities. A 72-year-old patient presents with newly diagnosed stage Roman III NSCLC. Their medical history is significant for moderate ischemic heart disease with a history of myocardial infarction 5 years ago and moderate chronic obstructive pulmonary disease, COPD. The patient is otherwise functional and expresses a strong desire for curative intent treatment. Considering the patient's complex medical profile, which of the following represents the most appropriate initial management strategy? Option A. Proceed with standard definitive chemoradiation therapy without further specialized evaluation, as the patient is otherwise functional and NSCLC is the primary concern. Option B. Initiate definitive chemoradiation therapy using intensity-modulated radiation therapy IMiT, with concurrent chemotherapy, after a thorough cardiopulmonary evaluation and discussion of potential treatment-related toxicities and dose adjustments. Option C. Refer the patient for surgical consultation for lobectomy, as surgery is the preferred curative modality for stage Roman III NSCLC, and radiation therapy is not indicated in this scenario. Option D. Recommend palliative radiation therapy alone to manage symptoms, as curative intent treatment is too high risk given the patient's cardiac and pulmonary history. The correct answer is B. Initiate definitive chemoradiation therapy using intensity-modulated radiation therapy, IMiT, with concurrent chemotherapy, after a thorough cardiopulmonary evaluation and discussion of potential treatment-related toxicities and dose adjustments. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, managing a patient with a complex medical history and a malignancy that can be treated with multiple modalities. The challenge lies in integrating the patient's comorbidities with the optimal radiation oncology treatment plan, ensuring efficacy while minimizing treatment-related toxicity and respecting patient autonomy. The physician must balance evidence-based guidelines with individual patient factors. Correct approach analysis. The correct approach prioritizes a multidisciplinary discussion and a thorough assessment of the patient's overall health status. This aligns with best professional practice by ensuring that the treatment plan is not solely based on the malignancy itself, but also on the patient's ability to tolerate and benefit from radiation therapy. This approach respects the ethical principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, by considering potential treatment-related morbidities in the context of the patient's existing conditions. It also implicitly supports shared decision-making by gathering comprehensive information to inform the patient about all viable options and their associated risks and benefits. This aligns with the general principles of patient-centered care expected within the regulatory framework governing medical practice. Incorrect approach is analysis, an approach that solely focuses on the most aggressive radiation technique without adequately considering the patient's cardiac history and pulmonary function would be ethically and professionally deficient. This fails to uphold the principle of non-maleficence by potentially exposing the patient to undue harm from treatment-related toxicity, which could be exacerbated by their comorbidities. It also neglects the principle of beneficence by not ensuring the patient can tolerate the proposed treatment, potentially leading to treatment interruption or failure. Another incorrect approach would be to dismiss radiation therapy entirely due to the patient's comorbidities, without a thorough evaluation of whether radiation could still offer a significant survival benefit or symptom palliation with appropriate dose modifications or alternative techniques. This could violate the principle of justice by denying the patient a potentially beneficial treatment option without adequate justification. It also fails to engage in a comprehensive assessment of treatment options. Finally, proceeding with a standard radiation oncology protocol without a specific discussion about the impact of the patient's comorbidities on treatment tolerance and outcomes would be a failure in informed consent and patient-centered care. This neglects the patient's right to understand the full implications of their treatment choices and the potential risks associated with their specific health profile. Professional reasoning. Professionals should approach such cases by first gathering all relevant clinical information, including the specifics of the malignancy and the patient's comorbidities. The next step involves consulting with relevant specialists, e.g., cardiology, pulmonology, to understand the implications of these comorbidities for treatment tolerance. A multidisciplinary team meeting is crucial to discuss the case and formulate a consensus recommendation. This recommendation should then be presented to the patient in a clear, understandable manner, outlining all treatment options, including the risks, benefits, and alternatives, with particular emphasis on how their comorbidities might influence outcomes. The final decision should be a shared one, respecting the patient's values and preferences. Question 13. Implementation of a radiation oncology treatment plan for a patient with a locally advanced head and neck squamous cell carcinoma requires careful consideration of the radiation sensitivity of various critical normal structures within the treatment volume. Which of the following approaches best reflects a comprehensive strategy for minimizing the risk of treatment-related toxicity while ensuring adequate tumor control? Option A. Focusing primarily on minimizing the dose to the spinal cord and brainstem, as these are generally considered the most radiosensitive structures in the head and neck region. Option B. Developing a treatment plan that strictly adheres to established dose volume constraints for all organs at risk, even if it necessitates a compromise in tumor dose coverage or a significant increase in treatment complexity. Option C. Utilizing a planning approach that balances tumor dose coverage with adherence to established dose volume constraints for critical organs at risk, incorporating patient-specific factors and potential synergistic effects with concurrent chemotherapy. Option D. Prioritizing the delivery of the prescribed tumor dose with minimal deviation, accepting that some dose escalation to adjacent critical organs may occur if it facilitates tumor coverage. The correct answer is D. Prioritizing the delivery of the prescribed tumor dose with minimal deviation, accepting that some dose escalation to adjacent critical organs may occur if it facilitates tumor coverage. Explanation. The scenario presents a professional challenge due to the inherent variability in radiation sensitivity among different normal tissues within a patient undergoing radiation oncology treatment. This variability directly impacts the potential for treatment-related toxicity and long-term sequelae. A radiation oncologist must exercise careful judgment to balance the therapeutic benefit of radiation to the tumor with the preservation of normal tissue function. This requires a deep understanding of radiobiology, clinical experience, and adherence to established guidelines and ethical principles governing patient care. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment of normal tissue tolerance. This involves utilizing established dose volume constraints, considering patient-specific factors, age, comorbidities, prior treatments, and employing advanced imaging and planning techniques to accurately delineate organs at risk. This aligns with the ethical imperative to minimize harm, non-maleficence, and act in the patient's best interest, beneficence. Regulatory frameworks, such as those guiding radiation oncology practice, emphasize the importance of accurate dose delivery and the protection of healthy tissues, often through adherence to consensus guidelines and quality assurance protocols. An incorrect approach that solely focuses on achieving a specific tumor dose without adequately considering the dose delivered to critical organs at risk represents a significant regulatory and ethical failure. This could lead to unacceptable levels of toxicity, violating the principle of non-maleficence. It may also contravene regulatory requirements for treatment planning that mandate the consideration of normal tissue dose constraints. Another incorrect approach, such as neglecting to account for potential synergistic effects of radiation with other treatment modalities, e.g., chemotherapy, demonstrates a failure to apply a holistic understanding of patient care, potentially leading to unforeseen and severe adverse events. This would be a failure to adhere to best practices in multidisciplinary care and could be considered a breach of professional responsibility. The professional decision-making process for similar situations should involve a systematic evaluation of the treatment plan. This includes 1. Thoroughly identifying and delineating all relevant organs at risk. 2. Consulting established dose-volume histograms and tolerance limits for these organs, considering the specific treatment intent and patient population. 3. Evaluating the trade-offs between tumor coverage and normal tissue sparing. 4. Incorporating patient-specific factors that might influence tissue sensitivity or tolerance. 5. Engaging in peer review and utilizing available quality assurance mechanisms to validate the plan. This structured approach ensures that treatment decisions are evidence-based, ethically sound, and compliant with regulatory expectations for safe and effective radiation oncology care. Question 14. Quality control measures reveal that a patient's daily radiation dose delivery has consistently been 5% lower than prescribed for the past 3 treatment days due to a subtle machine calibration drift. What is the most appropriate immediate professional action? Option A. Adjust the remaining treatment fractions by increasing the daily dose to compensate for the underdelivery, without further investigation into the calibration drift. Option B. Document the underdelivery in the patient's chart and wait for the next scheduled machine QA to address the calibration issue. Option C. Immediately halt treatment, investigate the cause of the underdelivery with the medical physicist, and determine the need for replanning or compensatory measures based on the cumulative dose deficit and clinical impact. Option D. Continue with the current treatment schedule, assuming the 5% underdelivery is within acceptable tolerance and will not significantly impact the treatment outcome. The correct answer is C. Immediately halt treatment, investigate the cause of the underdelivery with the medical physicist, and determine the need for replanning or compensatory measures based on the cumulative dose deficit and clinical impact. Explanation. Scenario analysis. This scenario presents a common challenge in radiation oncology, identifying and rectifying deviations from the prescribed treatment plan during the course of therapy. The professional challenge lies in balancing the need for timely patient care with the imperative to maintain treatment accuracy and adherence to the established plan, which is a cornerstone of patient safety and treatment efficacy. The potential for cumulative errors necessitates prompt and accurate assessment. Correct approach analysis. The correct approach involves a systematic review of the patient's treatment record, including daily logs, imaging verification, and dose monitoring, to pinpoint the exact nature and extent of the deviation. This is followed by a thorough assessment of the clinical impact of the deviation on the target volume and organs at risk. Crucially, this assessment must be performed by qualified personnel, typically the radiation oncologist and medical physicist, to determine the necessity and method of correction. This aligns with the fundamental principles of radiation oncology practice, emphasizing patient safety, adherence to the treatment plan, and the need for a multidisciplinary approach to quality assurance. Regulatory frameworks, such as those overseen by the Nuclear Regulatory Commission, NRC, in the U.S., mandate rigorous quality assurance programs that include the review of treatment delivery records and the management of deviations from prescribed doses. Ethical considerations also dictate that patients receive the treatment as prescribed, or that any deviations are carefully evaluated and managed to minimize harm. Incorrect approaches analysis. Continuing treatment without investigating the deviation fails to uphold the principle of patient safety and adherence to the prescribed plan. This represents a significant regulatory failure, as it bypasses established quality assurance protocols designed to detect and correct errors. Ethically, it is unacceptable to knowingly administer a treatment that deviates from the prescribed parameters without proper evaluation, potentially exposing the patient to suboptimal treatment or increased toxicity. Implementing a correction solely based on a superficial review of the daily log, without a comprehensive assessment of the deviation's impact on dosimetry and clinical outcomes, is also professionally inadequate. This approach risks overcorrection or undercorrection, potentially compromising treatment efficacy or increasing the risk of side effects. It fails to meet the standard of care and regulatory expectations for a thorough evaluation of treatment delivery errors. Making a correction based on anecdotal patient feedback alone, without objective data from treatment records and imaging, is a dangerous and unprofessional practice. Patient symptoms can be multifactorial, and attributing them solely to a treatment deviation without verification is speculative and can lead to inappropriate interventions. This approach disregards the established quality assurance processes and regulatory requirements for documenting and managing treatment errors. Professional reasoning. Professionals should approach deviations from the treatment plan with a structured, evidence-based methodology. This involves 1. Immediate identification and documentation of the deviation. 2. A comprehensive review of all relevant treatment data, daily logs, imaging, dosimetry reports. 3. A multidisciplinary assessment involving the radiation oncologist, medical physicist, and potentially dosimetrists and therapists to evaluate the clinical significance and potential impact. 4. Determination of the most appropriate course of action, which may include continuing treatment with adjustments, replanning, or interrupting treatment. And 5. Thorough documentation of the deviation, the assessment, and the corrective actions taken. This systematic process ensures patient safety, maintains treatment integrity, and complies with regulatory and ethical standards. Question 15. Market research demonstrates a growing availability of advanced treatment planning optimization techniques promising enhanced dose conformity and reduced treatment times. A radiation oncology department is considering adopting a new, proprietary optimization algorithm that claims significant improvements, but lacks extensive independent clinical validation. Which of the following approaches best aligns with regulatory requirements and professional best practices for implementing such a technique? Option A. Prioritize optimization techniques that demonstrably reduce planning time and associated labor costs, even if the clinical impact on dose distribution is marginal or unproven. Option B. Implement the new optimization algorithm after a thorough review of its technical specifications and a pilot study demonstrating its ability to achieve the claimed dose conformity improvements in a controlled setting, with a plan for ongoing outcome monitoring. Option C. Adopt the new optimization algorithm immediately due to its market presence and the potential for competitive advantage, assuming its advanced nature implies clinical superiority. Option D. Integrate the new optimization algorithm based on vendor testimonials and the perceived technological sophistication, without independent clinical validation or outcome assessment. The correct answer is B. Implement the new optimization algorithm after a thorough review of its technical specifications and a pilot study demonstrating its ability to achieve the claimed dose conformity improvements in a controlled setting, with a plan for ongoing outcome monitoring. Explanation. This scenario presents a professional challenge in balancing the pursuit of advanced treatment planning optimization with the practical constraints of resource allocation and regulatory compliance within the U.S. healthcare framework governing radiation oncology certification. The core difficulty lies in discerning which optimization techniques demonstrably improve patient outcomes and safety, as mandated by regulatory bodies like the FDA and professional standards, versus those that are merely technologically novel or driven by market trends, without clear clinical validation. Careful judgment is required to ensure that any adopted optimization strategy aligns with established evidence-based practices and does not introduce undue risk or cost without commensurate benefit. The correct approach represents best professional practice because it prioritizes optimization techniques that have undergone rigorous validation and are supported by evidence demonstrating improved clinical outcomes, reduced toxicity, or enhanced treatment delivery accuracy. This aligns with the fundamental ethical and regulatory obligation to provide safe and effective patient care. Regulatory frameworks, such as those overseen by the FDA concerning medical devices and software used in treatment planning, implicitly require that such technologies be demonstrably beneficial and not introduce new risks. Furthermore, professional guidelines from organizations like the American Association of Physicists in Medicine, (APM), emphasize the importance of evidence-based implementation of new technologies. An incorrect approach that focuses solely on adopting the latest, unproven optimization software without a clear clinical benefit assessment fails to meet regulatory and ethical standards. This could be considered a failure to adhere to the principle of primum non nocere. First, do no harm. If the unvalidated technique introduces unforeseen complications or compromises treatment efficacy. Ethically, it represents a potential misuse of resources and a deviation from the professional duty to act in the patient's best interest. Another incorrect approach, prioritizing optimization techniques that are primarily cost-saving without a demonstrable impact on clinical outcomes or safety, also presents regulatory and ethical concerns. While cost-effectiveness is a consideration in healthcare, it cannot supersede the primary mandate of patient well-being and adherence to established quality standards. Such an approach could violate regulations requiring the use of appropriate and effective medical technologies. The professional decision-making process for similar situations should involve a systematic evaluation of any proposed optimization technique. This includes reviewing peer-reviewed literature, assessing data from clinical trials or retrospective studies, consulting with multidisciplinary teams, physicians, physicists, dosimetrists, and considering the specific patient population and disease sites being treated. The decision should be driven by evidence of improved clinical outcomes, enhanced safety profiles, and alignment with current regulatory requirements and professional best practices, rather than solely by technological advancement or economic incentives. Question 16. The risk matrix shows a moderate probability of grade 3 acute xerostomia and a low probability of grade 2 late salivary gland fibrosis for a patient undergoing definitive chemoradiation for head and neck cancer. The patient is a 65-year-old former smoker with well-controlled hypertension. The treatment plan involves a dose of 70 Gi in 35 fractions to the primary tumor and involved lymph nodes, with dose constraints for organs at risk, including the parotid glands. What is the most appropriate clinical approach to manage this situation? Option A. Prioritize minimizing acute xerostomia by reducing the dose to the parotid glands, even if it slightly compromises the tumor dose, to ensure immediate patient comfort. Option B. Discuss the potential for both acute and late toxicities with the patient, emphasizing the importance of salivary gland protection techniques during treatment and the availability of supportive care for xerostomia, while proceeding with the planned treatment if the patient understands and accepts the risks. Option C. Focus solely on the low probability of late salivary gland fibrosis and reassure the patient that significant long-term issues are unlikely, proceeding with the treatment plan without extensive discussion of acute effects. Option D. Recommend abandoning definitive chemoradiation due to the moderate risk of acute xerostomia, suggesting alternative less effective but symptomatically milder treatments. The correct answer is B. Discuss the potential for both acute and late toxicities with the patient, emphasizing the importance of salivary gland protection techniques during treatment and the availability of supportive care for xerostomia, while proceeding with the planned treatment if the patient understands and accepts the risks. Explanation. Scenario analysis. This scenario presents a common clinical challenge in radiation oncology, managing patient expectations and clinical decisions based on the probabilistic nature of radiation-induced toxicities. The risk matrix, a tool for visualizing potential outcomes, highlights the inherent uncertainty in predicting individual patient responses to radiation therapy. The challenge lies in translating these statistical probabilities into actionable clinical strategies that prioritize patient safety and well-being while achieving therapeutic goals. It requires a deep understanding of radiobiology, clinical experience, and adherence to established guidelines. Correct approach analysis. The correct approach involves a comprehensive assessment of the patient's individual risk factors, the specific radiation treatment plan, and the potential for both acute and late toxicities. This includes a thorough review of the patient's medical history, comorbidities, performance status, and any prior radiation exposure. The radiation oncologist must then integrate this information with the predicted toxicity profile from the risk matrix, considering the dose, volume, and fractionation of the planned treatment. The decision-making process should be collaborative, involving the patient in discussions about the risks and benefits, and aligning the treatment strategy with their values and preferences. This approach aligns with the ethical principles of beneficence, non-maleficence, and patient autonomy, as well as regulatory requirements for informed consent and evidence-based practice. Incorrect approaches analysis. An approach that solely relies on the highest probability of acute toxicity without considering late effects or individual patient factors is flawed. This fails to acknowledge the long-term implications of radiation therapy and may lead to suboptimal treatment decisions that prioritize short-term symptom management over long-term quality of life. Ethically, it neglects the principle of non-maleficence by potentially overlooking significant late complications. An approach that dismisses the risk matrix entirely and relies solely on anecdotal experience is also problematic. While clinical experience is invaluable, it can be subject to bias and may not encompass the full spectrum of potential outcomes or the latest evidence-based understanding of radiation effects. Regulatory frameworks emphasize the use of evidence-based tools and guidelines to ensure consistent and high-quality patient care. An approach that focuses exclusively on achieving the highest possible tumor control dose, irrespective of the predicted toxicity profile, is ethically unsound and potentially violates regulatory mandates for patient safety. This prioritizes a single treatment outcome over the holistic well-being of the patient, failing to uphold the principle of non-maleficence. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough understanding of the patient's clinical context. This involves integrating objective data, such as imaging and pathology, with subjective information, like patient history and symptom reporting. The risk matrix serves as a valuable adjunct, providing a framework for understanding potential toxicities. However, it must be interpreted within the broader clinical picture. Ethical considerations, including informed consent and shared decision-making, are paramount. Professionals should continuously engage in lifelong learning to stay abreast of evolving research and guidelines, ensuring their practice remains evidence-based and patient-centered. Question 17. Investigation of a patient with locally advanced lung cancer who has researched hypofractionation and is requesting a significantly higher dose per fraction than typically prescribed for their stage and tumor location, citing anecdotal success stories. The radiation oncologist must decide how to respond to this request, balancing the patient's desire for a more aggressive approach with established radiobiological principles and clinical evidence. Option A. Propose a modified hypofractionation schedule that is less extreme than the patient's request but still deviates from standard practice, without a thorough review of the specific radiobiological implications and supporting clinical evidence for such a deviation. Option B. Immediately agree to the patient's requested hypofractionation schedule to honor their autonomy and perceived desire for aggressive treatment, without further discussion of potential risks or alternative evidence-based approaches. Option C. Engage in a detailed discussion with the patient about the radiobiological rationale for the standard fractionation schedule, explaining the concepts of tumor control probability and normal tissue complication probability, and the risks of increased toxicity associated with hypofractionation in this specific clinical context, while exploring the patient's underlying concerns and ensuring informed consent for the recommended plan. Option D. Firmly refuse the patient's request, stating that the prescribed fractionation is the only acceptable option, and dismissing any further discussion about alternative schedules or the patient's research. The correct answer is C. Engage in a detailed discussion with the patient about the radiobiological rationale for the standard fractionation schedule, explaining the concepts of tumor control probability and normal tissue complication probability, and the risks of increased toxicity associated with hypofractionation in this specific clinical context, while exploring the patient's underlying concerns and ensuring informed consent for the recommended plan. Explanation. Scenario analysis. This scenario presents an ethical dilemma where a physician must balance patient autonomy and the desire for aggressive treatment against established evidence-based practice and the potential for harm. The patient's request for a higher dose per fraction, driven by anecdotal evidence and a misunderstanding of radiobiology, directly conflicts with the standard fractionation regimen known to optimize tumor control while minimizing normal tissue toxicity. The challenge lies in respecting the patient's wishes without compromising their well-being or deviating from accepted professional standards, which are implicitly governed by the regulatory framework for radiation oncology certification. Correct approach analysis. The correct approach involves a thorough and empathetic discussion with the patient, explaining the scientific rationale behind the prescribed fractionation schedule. This includes detailing the principles of the linear quadratic model, the concept of the alpha-beta ratio, and how different fractionation schemes impact tumor cell kill versus normal tissue damage. The physician must clearly articulate the risks of increased toxicity, e.g., radiation pneumonitis, esophagitis, associated with hypofractionation in this context, referencing established clinical trial data and guidelines that inform best practice. This approach upholds patient autonomy by providing informed consent, while simultaneously adhering to the professional and ethical obligations to provide safe and effective care, as expected within the regulatory framework governing radiation oncology practice. Incorrect approaches analysis. One incorrect approach involves immediately acceding to the patient's request without adequate discussion or consideration of the biological implications. This fails to uphold the physician's duty of care and could lead to significant patient harm due to increased normal tissue toxicity, violating the fundamental ethical principle of non-maleficence. It also bypasses the informed consent process, as the patient is not fully apprised of the risks and benefits of the proposed deviation from standard practice. Another incorrect approach is to dismiss the patient's concerns outright and refuse to engage in a discussion about alternative fractionation. This disrespects patient autonomy and can erode trust, potentially leading to the patient seeking treatment elsewhere without proper oversight. While the physician's clinical judgment is paramount, a collaborative approach that educates and involves the patient is essential for ethical patient management. A third incorrect approach might be to agree to a compromise fractionation that is still outside of evidence-based guidelines, but is less extreme than the patient's initial request. This can be problematic as it still introduces unnecessary risk without a clear clinical benefit and may not fully satisfy the patient's underlying concerns. It represents a failure to adhere to established best practices and could still result in suboptimal outcomes or increased toxicity. Professional reasoning. Professionals should approach such situations by prioritizing patient education and shared decision-making within the bounds of evidence-based medicine. The process involves 1. Actively listening to and validating the patient's concerns and motivations. 2. Clearly explaining the scientific basis for the recommended treatment, including the radiobiological principles relevant to fractionation. 3. Discussing the potential benefits and risks of both the standard and any proposed alternative fractionation schemes, referencing relevant data. 4. Collaboratively determining a treatment plan that respects patient values while ensuring safety and efficacy, and documenting this discussion thoroughly. Question 18. What factors determine the scope and frequency of quality assurance activities for a linear accelerator used in radiation therapy, ensuring compliance with regulatory standards and patient safety? Option A. The manufacturer's recommended maintenance schedule, independent end-to-end treatment verification audits, and ongoing staff competency evaluations. Option B. The number of patients treated daily and the perceived reliability of the linear accelerator based on historical incident reports. Option C. The availability of advanced imaging features and the frequency of software updates for the treatment planning system. Option D. The cost-effectiveness of performing specific quality assurance tests and the convenience of scheduling maintenance. The correct answer is A. The manufacturer's recommended maintenance schedule, independent end-to-end treatment verification audits, and ongoing staff competency evaluations. Explanation. The scenario presents a common challenge in radiation oncology, ensuring the accuracy and safety of treatment delivery while managing the complexities of evolving technology and patient care. The professional challenge lies in balancing the need for rigorous quality assurance with the practicalities of daily clinical operations, including patient throughput and resource allocation. Careful judgment is required to prioritize QA activities that have the most significant impact on patient safety and treatment efficacy, aligning with regulatory mandates. The correct approach represents best professional practice because it directly addresses the core principles of radiation oncology quality assurance as mandated by regulatory bodies such as the Nuclear Regulatory Commission, NRC, and the American Association of Physicists in Medicine (OPPM) guidelines, which are foundational for the radiation oncology certification exam. This approach emphasizes a systematic, risk-informed strategy that integrates regular equipment performance checks, patient-specific plan verification, and ongoing staff competency assessments. This aligns with the regulatory requirement for comprehensive QA programs designed to minimize errors and ensure accurate dose delivery, thereby protecting patients. An incorrect approach that focuses solely on patient throughput without adequate QA checks would represent a significant regulatory and ethical failure. This would violate the fundamental principle of do no harm and contravene regulations, requiring documented QA procedures to ensure treatment accuracy. Similarly, an approach that neglects independent verification of treatment plans, relying only on the treating physician's review, fails to implement a critical safety barrier mandated by regulatory standards, increasing the risk of dose delivery errors. An approach that prioritizes new technology adoption over established QA protocols would also be a failure, as regulatory frameworks require that all equipment, new or old, undergo rigorous testing and validation before clinical use to ensure it meets performance specifications and safety standards. The professional decision-making process for similar situations should involve a hierarchical approach to risk assessment. First, identify all potential sources of error in the radiation therapy process, from imaging and simulation to treatment planning, delivery, and follow-up. Second, evaluate the likelihood and potential severity of harm associated with each identified error. Third, implement QA measures that are proportionate to the identified risks, prioritizing those that offer the greatest protection against serious harm. This involves adhering to established protocols, maintaining meticulous documentation, and fostering a culture of continuous improvement and open communication regarding potential safety concerns. Professionals must remain current with regulatory requirements and best practice guidelines to ensure their QA programs are robust and effective. Question 19. When evaluating the fundamental principles of radiation therapy in a clinical setting, a radiation oncologist is presented with a case requiring the application of established treatment modalities. The oncologist must correctly identify the nature of the radiation used in standard external beam radiotherapy to ensure appropriate safety measures and treatment efficacy. Which of the following classifications accurately describes the radiation employed in typical external beam radiotherapy, such as cobalt-60 or linear accelerator-produced photons? Option A, thermal radiation. Option B, electromagnetic radiation. Option C, ionizing radiation. Option D, non-ionizing radiation. The correct answer is C, ionizing radiation. Explanation: scenario analysis. This scenario presents a professional challenge in accurately categorizing radiation types and their implications for patient safety and treatment efficacy. Misunderstanding the fundamental differences between ionizing and non-ionizing radiation can lead to incorrect treatment planning, inadequate safety protocols, and potential harm to patients and staff. The challenge lies in applying theoretical knowledge to a practical clinical context, ensuring that the chosen approach aligns with established scientific principles and regulatory guidelines for radiation oncology. Correct approach analysis. The correct approach involves recognizing that therapeutic radiation used in oncology, such as X-rays and gamma rays, are forms of ionizing radiation. This classification is critical because ionizing radiation possesses sufficient energy to remove electrons from atoms and molecules, thereby directly or indirectly damaging cellular DNA. This property is the basis for its use in cancer treatment, radiotherapy, to induce cell death in malignant tumors. Furthermore, understanding this classification dictates the stringent safety measures required, including shielding, dose monitoring, and personnel training, as mandated by regulatory bodies governing radiation safety. Incorrect approaches analysis. Classifying therapeutic radiation as non-ionizing radiation is a fundamental error. Non-ionizing radiation, such as radio waves, microwaves, and visible light, does not have enough energy to ionize atoms. While it can cause heating effects, it does not directly damage DNA in the same way as ionizing radiation. Applying safety protocols designed for non-ionizing radiation to ionizing radiation would be grossly insufficient, leading to unacceptable radiation exposure risks. Similarly, assuming that all forms of radiation are interchangeable in their biological effects ignores the distinct physical properties and mechanisms of action that differentiate ionizing from non-ionizing radiation, leading to potentially dangerous clinical decisions. Professional reasoning. Professionals in radiation oncology must maintain a robust understanding of the physics of radiation. When faced with a clinical scenario involving radiation, the first step is to identify the specific type of radiation being used. This involves recalling or verifying whether the radiation has the energy to cause ionization. This classification then informs the subsequent decisions regarding treatment planning, dose calculation, and, crucially, radiation safety protocols. Adherence to regulatory frameworks, such as those established by the relevant national health and safety authorities, is paramount. Continuous professional development and a commitment to evidence-based practice are essential to navigate these complexities and ensure patient and staff safety. Question 20. Operational review demonstrates that a patient requiring urgent initiation of radiation therapy presents with complex comorbidities that necessitate input from medical oncology and surgical oncology for optimal treatment planning. However, the scheduled multidisciplinary tumor board meeting is not for another 48 hours, and delaying treatment could negatively impact the patient's prognosis. Which of the following actions best upholds the principles of multidisciplinary care and regulatory compliance in this scenario? Option A. Proceed with radiation therapy immediately, relying on informal verbal consultations with medical and surgical oncology to gather their perspectives. Option B. Delay the initiation of radiation therapy until the scheduled multidisciplinary tumor board meeting, ensuring all specialists are present for the formal discussion. Option C. Initiate radiation therapy based solely on the radiation oncologist's assessment, assuming the other specialists would concur given the urgency. Option D. Initiate radiation therapy based on the radiation oncologist's assessment, documenting the rationale for proceeding without immediate multidisciplinary input due to urgency, and schedule a formal review at the next tumor board meeting. The correct answer is D. Initiate radiation therapy based on the radiation oncologist's assessment, documenting the rationale for proceeding without immediate multidisciplinary input due to urgency, and schedule a formal review at the next tumor board meeting. Explanation. Scenario analysis. This scenario presents a common implementation challenge in multidisciplinary cancer care, ensuring seamless communication and integration of diverse clinical perspectives within the established regulatory framework for patient care. The challenge lies in balancing the need for timely, comprehensive patient management with the procedural requirements of a multidisciplinary tumor board, particularly when patient acuity demands immediate intervention. Professional judgment is required to navigate potential delays, ensure all relevant specialists are informed and contribute, and maintain the integrity of the treatment planning process. Correct approach analysis. The correct approach prioritizes the timely and documented inclusion of all relevant specialists in the multidisciplinary tumor board discussion, even if a formal meeting cannot be immediately convened. This aligns with best professional practice by ensuring that patient care decisions are informed by a comprehensive range of expertise, as expected in a multidisciplinary setting. Regulatory frameworks for radiation oncology certification emphasize the importance of collaborative decision-making and comprehensive patient assessment. Documenting the rationale for any deviation from a standard meeting schedule and ensuring all necessary input is obtained and recorded upholds ethical obligations and regulatory compliance by maintaining a clear audit trail and demonstrating due diligence in patient management. Incorrect approaches analysis. One incorrect approach involves proceeding with treatment initiation based solely on the radiation oncologist's assessment without documented input or consensus from other key specialists. This fails to meet the core principle of a multidisciplinary approach, potentially leading to suboptimal or incomplete treatment plans. Ethically, it breaches the duty to provide comprehensive care informed by all available expertise. Regulatory failure occurs because it bypasses the established process for multidisciplinary review, which is often a requirement for accreditation and quality assurance in radiation oncology. Another incorrect approach is to delay treatment significantly while awaiting a formal, in-person tumor board meeting, even when patient condition suggests urgency. While adherence to process is important, patient well-being must be paramount. This approach can be detrimental to patient outcomes and may violate the ethical principle of beneficence. Regulatory failure arises from a rigid interpretation of process that compromises patient care, potentially indicating a lack of adaptability in the multidisciplinary team's operational procedures. A third incorrect approach is to rely on informal, undocumented consultations with other specialists. While informal discussions can be helpful, they do not constitute the formal, documented multidisciplinary review required for robust patient management and regulatory compliance. This approach creates an unacceptable risk of miscommunication, missed critical information, and a lack of accountability, all of which are contrary to best practices and regulatory expectations for comprehensive cancer care. Professional reasoning. Professionals should approach such situations by first understanding the specific requirements of their institution's multidisciplinary tumor board protocols and relevant regulatory guidelines. When immediate formal review is impossible, the decision-making process should involve 1. Assessing the urgency of the patient's condition. 2. Identifying all essential specialists whose input is critical for the immediate treatment decision. 3. Initiating documented communication with these specialists to obtain their input e.g. via secure electronic consultation, recorded phone calls. 4. Documenting the rationale for any deviation from the standard protocol and the input received. And 5. Ensuring that the formal tumor board review occurs as soon as feasible to ratify or adjust the initial plan. This structured approach balances patient needs with the imperative for collaborative, documented, and compliant care.